Welcome back, guys. So, in this module, what we are going to see is about how wound healing happens, repair, regeneration, and different types of wound healing, the primary intention, the timelines of wound healing, and we'll be ending with disorders of wound healing and a famous keloid as well, right? That must have been a first portal for most of you in a medical college. You must have diagnosed it and must have felt happy for yourself, right? You're just going to rejoice that happiness, okay? So what we have done till now in inflammation chapters, we have done with acute inflammation, we have done with chronic inflammation. The only part which is left behind is wound healing. That's what we are going to see today. Fine. Are you ready? If you're ready, put a smile on and let's start. Right. So we are going to the basics of wound healing. How we are going to divide this module is we are going to say what are the terminologies we use, like we use repair, we use regeneration, we use scar formation in different places. That's what we are going to see when I'm going to use these terminologies and why I have different types of mechanism for different tissues. So we are going to divide the cell based on my regenerative capacity. That also we are going to do it here. And we are going to see the steps of wound healing. We'll first discuss the different steps of wound healing. Then we'll put together in a timeline to see what is an wound healing by primary intention, right? And then the disorders of wound healing, fine? Ready? So first we are going to go to a few basic terminologies. We always use these terms very loosely, but they do have an implication. We have something called as repair or healing. These are two basic terms, right? So where should I use repair scientifically when I am correct, and when scientifically I should use term healing? I'm going to use the term repair. See, both means one and the same. Okay, both means one and the same. That's all. It's a complete or incomplete restoration of an injured, damaged tissue, right? I'm going to use the term repair. Then I'm going to have problems in my epithelia. I'm going to use the term healing when I'm going to have problems in my tissues like heart and everything, right? So here I'm going to use the term repair. Sorry, I actually said the wrong way, ulta way, right? I'm going to use the term repair. Ignore that. I'm going to use the term repair when it's going to be injury and the response of my body to injury to parenchymal organs, right? To parenchymal organs, and I'm going to use the term healing when I'm going to say to the superficial epithelia or my surface epithelia. These are the terms generally used. Maybe to remember like this, heart never heals. You guys know that, right? Some of you guys know that, right? It's going to get repaired. And healing is my surface. My skin, I got a wound and it healed, right? Those are my basic terminology. But in many places throughout your life, as well as throughout your medicine, you will see these terminologies getting interchanged, right? And how does an healing or how does a repair or how does a damaged tissue get healed? I have two basic things. It can get regenerated, which means it can come completely the same way what damage was happened, or it will heal by a scar formation, right? So we're going to have two things. This repair or a healing process happens. We have two mechanisms. One is going to be regeneration. The regeneration, as the same as the name says, that whatever is being lost is going to come back to the normalcy. That's regeneration, right? Which means the lost tissue is getting replaced by a new tissue. Other one is going to heal by scar formation or repair by scar formation. Yeah, I'm sure you guys know what a scar formation means. It's going to have a scar during the process of healing or repair. These are two main ways by which a body can come back to its normalcy: regeneration or repair, or a scar formation. So what decides me, okay, this is going to get regenerated, and what decides me, okay, I'm having an injury here, this is going to become a scar formation. It's going to result in a scar. What decides is the tissue which undergoes the damage. It's everything is based on the tissue, right? So we're going to divide the tissue, or we're going to divide the tissues or the cells into different subtypes. We call some of them as labile cells, we call some of them as stable cells, and we call few of them as permanent cells. Permanently not able to divide, right? That's the base of whether it's going to go to regeneration or it's going to go to scar formation, right? Let's go and see about it. So we have cells or tissues divided into three major subtypes. The first one is called labile or continuously dividing cells. Okay, they continuously keep on dividing. Okay. Ignore my spellings. Fine. You're continuously dividing cells, which means these cells are always in the cell cycle. I don't want a stimulus. It will be there. Once a cell dies, new cell comes. When cell dies, new cell comes. Automatically, always, always, again and again. What's the best example? I'm sure you guys know skin. Skin always divides. GIT always divides. Epithelium always divides. So these are labile or continuously dividing cells. These cells are always in cell division. They are always in cell division. They will be continuously replaced by new cells from stem cells. From stem cells, they will be continuously replaced. They'll automatically, again and again, it will come back to normal, simply just like that, right? Those are my continuously dividing cells. What are the examples? Examples of continuously dividing cells are the major cells, hematopoietic stem cells in the bone marrow. I'm sure you know that. Epithelium of various tissues, surface epithelium of GIT, name any organ like skin. Skin also will get regenerated, uterus, fallopian tube, lots. Okay? Lots of them will keep on regenerating, right? Will keep on regenerating. There's no one to required for a stimulus for that. It's lost, it'll keep on regenerating. It's continuous regeneration. So when I have a problem, when I have an injury in this, my skin is getting injured, a slight injury, it will completely regenerate. Try to bring the best possible outcome because it's always regenerating. Whenever a tissue is lost, it can replace it. The type of damage here, if there is a damage to these organs, you will have a complete regeneration. The outcome will be in complete regeneration. That's what I'm going to look at here, right? Whenever I have injury to all these organs, it will more or less completely regenerate. There will be an evidence of injury there, but more or less will completely try to regenerate. Those what happens with labile cells. Then we'll see what happens to the next group of cells called as stable cells or stable tissues. These cells are not continuously dividing. They are in G0 phase of cell cycle. We read cell cycle. We will read cell cycle in neoplasia chapter. They are in G0 phase of cell cycle. They are not dividing. They are resting phase. These cells stay in G0 phase of cell cycle. Does it mean that they can't divide? No. Obviously they can divide, but I need a stimulus. Only when I have a stimulus, only when I have a damage, I have a stimulus, I have a growth factor, they are going to divide. They are not continuously dividing. They have the capacity to divide, but they are dormant like us. We have the capacity to learn, but we wait for a stress, which is exams, then we go to learn, right? We should be labile cells, we should not become stable cells, right? So these are like us. They can divide, but only in response to injury. Okay? Only in response to an injury, they're going to divide. Otherwise, they don't divide. They are always in resting phase. Aram say they'll be sitting there. No problem will happen, right? So what are the cells which come under them? Examples. Parenchymal organs. Parenchyma of liver, kidney, and pancreas. These parenchyma, I'm not talking about the epithelium, I'm talking about the parenchyma. So liver parenchyma can regenerate, but do not regenerate continuously. When I'm going to take a lobe of a liver, you guys know that it can undergo tremendous amount of hyperplasia. Because of this, they can divide and try to give back the tissue again, right? So parenchyma is an example. Another example is endothelium. Endothelium also will undergo injury. When there's an injury, they'll try to come back by stimulating my cells, right? Endothelium is a stable cell. Your smooth muscle cell, put a star here in the smooth muscle, I'll tell why as well. Your fibroblast are also stable cells. Why I asked you to put a star in smooth muscles? The next other two muscles, cardiac muscles and your skeletal muscles, will be reading them under permanently divided cells. So I don't want you to get confused for smooth muscles, right? Smooth muscle is a stable cell. Other two muscles are more or less a permanently divided cell, right? So when I'm going to have an injury here, when there is a damage to any of the stable cell, what will happen? When there's damage, I will have the capacity to regenerate, but very limited. I'll not have complete regeneration like what we had in labile cell. There is a limited capacity to regenerate. They will try to regenerate, but a limited capacity to regenerate. There's limited capacity to regenerate, and there's always an exception. Exceptions are always MCQs. Exception, you guys know that. Exception is liver. Liver has a tremendous capacity to regenerate. It's one of the best organ which can come back to normal even if you kick it to the ground, right? Like your Phoenix bird, right? They're going to come back to normal. That's about stable cells. So we saw labile cells, we saw stable cells. One more thing which is left is my permanently divided cells, or we call them as terminally differentiated cells. The third group of cells are going to be permanent tissues or permanent cells. We also have one more term, they are also called as terminally differentiated cells. Okay. We have terminally differentiated cells or tissues as well. There's the other name, permanent tissues or terminally differentiated tissues. So what do I mean by that? There are few cells in our body which has lost the capacity to regenerate. They are like, okay, I have from a stem cell, I became this cell and I'm going to stay there. I'm not going to do anything. Like HOD is not going to do anything. I'm just going to stay there. Till I'm alive, I'll be there. Once I am gone, the tissue will look for no other replacement. They are permanently divided tissue. They are terminally divided tissue, or they have lost its capacity to regenerate. They have lost its capacity to regenerate. Okay, that's what we call them as permanently divided tissue. They are out of the cell cycle totally. They are permanently divided. No amount of stimulus can make them do their work again. So what will happen? Let's just assume that I'm having a brain, CNS is a permanently divided tissue, or cardiac muscle is a permanently divided tissue. I'm having a cardiac muscle injury. I'm not able to replace it completely. So who will come and help me? Perfect, fibrous tissue. In other words, when all these organs undergoes damage, the replacement will be by fibrosis or scar formation. I don't have an option to regenerate to my maximum effect. They can't do it, right? So examples of permanently divided tissue are CNS and muscle, of muscle, cardiac muscle, and skeletal muscle. Okay. Here also put a star mark here. I'll tell why. These are all permanently divided or terminally differentiated cells. So why I asked you to put a star mark in your skeletal muscle is, Robbins says that skeletal muscle, though it's a permanently divided tissue, there are recent evidences which says that there are few cells called as satellite cells. They can try to divide and bring back they are like stem cells. They can try to divide and try to bring back a damaged skeletal muscle. They have said that, but still same Robbins put them under permanently divided tissue only. So if asked as an MCQ, please look at the other options. If this is the best answer, go for the best answer, right? Why it's the star is, there are satellite cells which are stem cells in a muscle, in a skeletal muscle. They can regenerate, they can replace, which have the capacity to replace them. They have the capacity to replace a damaged tissue. There are evidences for cardiac muscle as well. Even there are evidences for CNS as well. But still I keep them in permanently differentiated tissue only. So when I have a damage, when anyone has a damage in a permanently tissue or a terminally differentiated tissue, they are going to heal by scar formation only, or repair by scar formation only. Okay? The outcome is almost always scar formation. Regeneration is very, very limited because they don't have the capacity to regenerate, right? So we read that healing or scar repair has two ways. One is going to complete regeneration, happens in labile tissues always, and in a stable tissue most of the time. Scar formation always happens in my permanently divided cells, right? We have sorted about which all organs will have what type of reaction. That's what we did here. Next, what you're going to do is, we're going to take a detour and go to little bit about stem cells. Stem cells is like always a fascinating topic, right? From the time when I wanted to do an MBBS, this was like, I want to do a stem cell research. Right in second year, I want to do a stem cell research. research in stem cell makes us euphoric. It's been there for decades. We have been saying that it's gonna replace everything in future for decades, and we are still hoping for the break-even point. But yes, it has the capacity, it has the potential. That's why it is being glorified like that. So to go to that level, we need to know what is a stem cell, what are the different types of cells which we have to understand about, right? I'll just give you an example, little bit in detail about stem cells, not too much in depth. So stem cells, what are they? So stem cell is unique for the only instance they can keep on dividing n number of times, and they can also differentiate. That's a unique thing about a stem cell. So stem cell, I'm going to have two different types. A stem cell during my early embryonic period and stem cell in my late embryonic period and my adult life. We have two different types because both of them have slightly different property, right? So we're going to divide a stem cell during an early embryonic life and a stem cell during later life. Later during life or later during adulthood. So I'm going to ask you a question and you are going to say the difference between these two. I'm having a cell during my early embryonic life, like during zygote formation. Let's say foster stage, I am having a stem cell. What do you think is the main purpose of the stem cell there? To create many new cells or to create a developed neuron or a developed muscle? At a very early embryonic stage, my main purpose is to create more new cells. So what happens to this early embryonic stem cell is, these stem cells here, when they divide, they'll become two new cells, and both of the cells will retain the capacity to divide again. They'll again keep on dividing, right? Their only purpose is division. They keep on dividing again and again and again and again, so this again populate more number of cells. An early embryonic stem cell has lots of division as the property. This is called as symmetric division, which means one cell divided into two cells. These two cells also can divide into two more cells. Those two cells can divide into two more cells, like a nuclear fusion reaction, right? There's a symmetric division. I also have something called as an asymmetric division. What do I mean by that? Okay, let's assume that from the early embryonic period, I have come to my, let's say, 9 weeks or something. Just for an example, and these numbers are just example. 9 weeks of gestation. So I have got a good amount of fetal mass. I've got good amount of fetal mass. In thoracic, I'm having stem cells. Thoracic cavity. So here now, what do you think will be the property? To create heart, lung and great vessels, or to keep on creating tissues, that's all, with no specialization. Obviously, the function after certain point is to create function, right? It has to create a unique specialized tissue. That's what happened to the stem cell in later life. We call them an asymmetric division. I'll tell what does it mean. So in later during life, what happens is, we have stem cells, we don't have a defining point which is early, which is late, but later during life, we have a stem cell, they will divide. They divide like same thing what we saw into two new cells. When they divide into two new cells, one cell retains the capacity of further division. Okay? One cell, during every division, one cell retains the capacity to further divide, further divides. And during every cell division, the other cell will lose its capacity to divide but will become differentiated. Very important. Differentiation is specialization, right? So other cell, this cell, or maybe when this divides again, this cell also joins this pool. I'm saying with every division, I'll have a division, this divides again, this goes to differentiation. Divides again, goes to differentiation. With every division, one cell will retain the capacity of cell division so that my stem cells don't get destroyed. Other cell goes into a process of differentiation. Okay? Other cell goes into the process of differentiation. That's what I mean here. So what does differentiation means? Becoming a specialized tissue, right? It becomes a specialized tissue. Any specialized tissue. I'm not saying just heart, any specialized tissue. Wherever they are, that specialized tissue. This property of stem cell, I'm going to call it an, you guys know it, you're going to name it asymmetric division. It's not symmetric, right? because one retains a property, other goes to a specialized tissue. It's an asymmetric division. So stem cells have a property of both symmetric division as well as asymmetric division. We need to know this. This is the basic property of stem cells. I'm sure when you saw the video on embryo hematopoiesis, you must have heard me saying pluripotent stem cell, multipotent stem cell, lots of things. You must have also heard me somewhere saying totipotency. So what is the difference between these potency? We have to know about them, right? It's something intriguing, something new for us. Toti, total. So stem cells, you have different types. First one is called as totipotent stem cells. When I call something totipotent stem cell, they can form everything in the body, including placenta, which means they can form all three germ layers, and also they can form extra embryonic tissue, your yolk sac, your placenta. Not only embryo, it also helps in the formation of extra embryonic tissue, the placenta. That's a totipotent stem cell. It has the total capacity, totipotency. A problem in my totipotent stem cell will give rise to a teratoma. And we'll read them when we come to the female genital and male genital tract, right? Okay. Next is pluripotency. What does pluripotency means? Pluripotent stem cell means they can form all germ layers. They can form all germ layers, but they can't form placenta. Only germ layers, only the fetus, not the extra embryonic tissue. That's the difference between this and that. No extra embryonic tissue. Okay. That means no placenta. The best example for pluripotent stem cells, I'm writing hematopoietic stem cell. One group of hematopoietic stem cell is pluripotent. This feature we are going to harness. We're going to use it for our good. So what we say is, I'm having a stem cell in the bone marrow which has the capacity to form any cell in my body. Why should I waste them? I'm going to use them. Right? I'm going to use them. How? Immediately after a baby is born, these days what we have is we have something called as an umbilical cord stem cell storage, right? We have something called that. So immediately after baby is born, immediately after birth, what we do is we take the umbilical cord blood. We take the umbilical cord blood and we are saying that this umbilical cord blood will have pluripotent hematopoietic stem cells. So they have that. What I'm saying is I can create any cell from this cell. Not only blood, I can create heart, I can create neurons. So this is a pluripotent hematopoietic stem cell. So here I'm going to say this can become any cell. It can become the blood if I want to, it can become heart, it can become neuron, it can become muscle, any muscle, whatever I want to. Based on the growth factors, I can push them to whatever lineage I want. So I'm saying that I'm going to store the umbilical cord blood of a newborn baby. The most important thing is to maintain the temperature. I have to perfectly store. So that let's assume, just an assumption, this kid has a problem or heart attack like at 70 years of age. So I'm going to say, take the guy which we have stored. Take the guy. Put the growth factors to become a cardiac muscle. Take the cardiac muscle once it's formed. Inject to the infarcted myocardium. Replace the heart, make it beat again. That's the ultimate goal. We are not yet there, but I'm sure we will be there sometime in future. Right? That's the use of umbilical cord blood transplant, storage, and the potency of my pluripotent stem cell. Next is third one, multipotent stem cells. Multipotent stem cells, majority of the adult stem cells are multipotent. Very few are pluripotent, majority are multipotent, which means, let's take, say in the bone marrow itself we'll take, the first stage was pluripotency, the next stage was multipotency. So what I say by multipotent is, they can form blood cells, RBC, WBC platelets, but not neurons. That's multipotency. It's lineage specific. Okay? Which means it can form only one lineage. What I mean by that is, if it's a multipotent hematopoietic stem cell, HSC is hematopoietic stem cell, they can form RBC, WBC and platelets to the max. But they can never ever think of forming a neuron. Not only neuron, Anything which is not blood, they can't form. That's multipotency. You can form one thing, that's all. Nothing more than that. Most of the adult stem cells are multipotent. We have stem cells in different places in our body. Just give a few examples. In liver, we have stem cells, we call them as oval cells. We have them, I think, in a place called as canals of herring. Okay, we have in canals of herring, we have stem cells called as oval cells. We just now saw in your skeletal muscle, what are cells called as? Perfect. Satellite cells. They are also adult stem cells. In skeletal muscle, we just now saw, we have something called as satellite cells. They are also stem cells. They are also adult stem cells. Skin, my basal layer of skin is a stem cell. It regenerates. I also have a store called as a bulge cell. It's near the bulge of the hair follicle. In skin, there's a bulge in hair follicle, the stem in the hair follicular region, which helps to regenerate everything. Those are also stem cells. I have multiple examples for stem cells. We'll read them when we come to individual organs and how it helps also, we'll read them, right? This is in short about stem cells. Why we took a detour is, we need to know why few organs multiply and why few organs didn't multiply, why few are stable and why few are permanent. This in Robbins will become the first chapter. Cell as a basic unit of health. I'm not putting that video separately. What I'm doing is I'm incorporating a little bit of it here and there. Here we saw about stem cells. When we come to neoplasia, we'll see about cell cycle. When we come to another place, we'll see about few things about that. It's just a combination of everything. Instead of reading it as a chapter, which becomes boring without a clinical implication, we're just dragging it and putting it in the right spot so that you will remember for sure. That's the ultimate goal, right? We have to try to link everything. Okay? So now we have the base. We have all the base set for me to learn wound healing. I know which organ forms what, which tissue forms what, why it forms that. Now what we are going to do is, we are going to see the steps of wound healing. Slowly, one by one. With an example of healing by primary intention. Right? We're just going to see the steps of wound healing with an example called as healing by primary intention. That's what we're going to see now. Right? Now what we're going to do is, we're going to see the steps of wound healing. I'm going to talk like someone. Okay? We're going to see the steps of wound healing. So we're going to take something called as healing by primary intention. So what do I mean by primary intention? What do I mean by secondary intention? So primary intention is something when I'm going to have a tiny wound without a massive tissue loss, like an incision, a surgical incision, a primary intention. At the same time, when you fall down, you are having a laceration, you are having a wound loss, a tissue loss. I'm going to call that healing by secondary intention. Both will have more or less the same thing overall. But there will be tiny changes based on the duration and based on the amount of scar tissue formed, right? So for our ease, we are going to learn an healing by primary intention or first intention. We are going to learn the steps of wound healing by this so that it's easier for us. Healing by primary intention means they are clean and less tissue loss. Okay? They are just less tissue loss, which means less scar formation and less amount of one tissue called as granulation tissue. We'll see them, right? So we'll have less granulation tissue. We'll see what they mean. And they'll have less tissue loss. Okay? And less scar formation as well. But when I say healing by secondary intention, I'll just put a table here. When it's healing by secondary intention, okay, it's a lacerated wound, a huge tissue loss like a laceration, an extensive tissue loss, plus it will be infected more often, right? So I have an extensive tissue loss and I have infection. When it heals, I will have scar. Or in other words, I call it wound contraction is more here. There will be more contraction here compared to the other one. Fine. There's a basic difference between primary intention healing and secondary intention healing. We know the base. We know what are the things involved. Now we are going to go to steps. Steps of wound healing. I want you to remember, and definitely I'm sure that you must have got injured some point in your life. I'm talking about your physical injury. Your abstract injury, I'm not bothered about, right? When you have a physical injury, like example, you fell down or you cut with the help of a knife, you must have fallen down at least one point in your life. When you fall down, the first thing what happens? It will bleed. After some time, bleeding will stop. We know the bleeding cascade, we know the clotting cascade, it will stop. After you'll have something called as brown color overlay will be there. If you remember, your mom would have said, don't remove that. Your mom would have said, don't remove that. Your mom would have also said that if you remove that, healing will not be proper. That's called as a scab. When you remove a scab, healing will not be proper. Robin says that. You were studying that after 20 years. Your mom knew it. Your mom know more medicine than you. The only reason is she don't know the reasoning. The only difference you and a layman is reasoning. The power of knowledge is the most important. And obviously experience is more important as well. So we're going to learn from our experience and put science into it and create magic. So why a scab is so important is, let's assume like this, I'm just giving you an example. I'll go through the steps one by one. Don't write now. Let's assume I'm having this is skin. The cleft is the cut. This is a place where my clot or scab forms. My goal here is to unite the cut area, right? So if I have to unite the cut area, obviously my neutrophil should come, macrophage should come, will have to deposit your collagen and everything. For that, I need a base. I cannot form collagen like this. I'm not a magician, right? I cannot form a collagen just like that. I need a base. That base is your scab. Let's, for an instance, I'm saying that my neutrophils, everything will come here. Macrophage will act on the scab. Let's, for an instance, assume that you remove the scab. Right? Remove the scab. I don't have a space. My neutrophils, whichever came, will be gone now. Cannot bridge the gap. What it has to do again? Again bleed, again form a scab, again start from the first. That's what your mom would have told. You remove that, it will again go the same routine process. That's how important scab is. Fine? Got it. So we got a scab. After a scab is being formed, put your pens down. We'll first understand, then we'll learn. After a scab is being formed, the first cell to come in any place is neutrophil. Neutrophil will come inside, inspect the area. Is there any bacteria? Because when I have a cut, common cell can go inside. Okay, engulf the bacteria, destroy them. Any tiny little dirt, destroy them. So my neutrophils came, cleared the ground. After a few hours, who will come? Macrophages will come. When macrophage comes, macrophage will come to the place and say, okay, neutrophil, have you done your job? Yes, eat the neutrophil. The first step, use of macrophage. After that, now everything is clean. I have one most important thing is I have to initiate the healing process. That also a macrophage is only going to do. You're going to say which macrophage? Normal or activated? Perfect. I can hear you say activated. What type of activation? M1 or M2? Again, amazing. M2 activation. We read them in chronic inflammation, right? So as macrophage came, ate all the neutrophils, waiting for the signals, and from that they become M2 activated macrophage. Once they become an M2 activated macrophage, they're going to secrete growth factors like VEGF, FGF, PDGF, TGF beta. Once all these comes, they're going to bring in more blood vessels, more fibroblast, more collagen, forms a tissue called as granulation tissue. Once a granulation tissue is being formed, the next thing for me is I have to make it permanent. In order to make it permanent, I'm going to produce more and more collagen, more and more myofibroblasts will come so that it can contract. So it becomes my permanent scar. I'm going to form a scar. My job is not yet done. This scar is new. This scar is weak. How do I make anything strong? You're going to answer me. How do I make anything strong? How do I make my bone strong? Lay, remove. Osteoblast, osteoclast, osteoblast, osteoclast. I have to put layers of them. That's called as remodeling. My thing is not at stop. I have to remodel. So I have a collagenous scar. I have to remodel. Whom do I require now? Perfect. I require collagenase. Inflammation chapter. Which had collagenase? Which had collagenase? Granules. I'm going to have the same inflammatory cells, same macrophages release granules again. Matrix metalloproteinases. They're going to release, remove the collagen, form the collagen. Remove the collagen, form the collagen. So that it becomes more stronger. Even if all the activities, after 3 months, I'll get the best strength of the wound, which is 70% of normal. It's not 100%. You can never become 100%. In your exams also, you can never become 100%. I'll maximum have 70 to 80% of normal. That's what your body teaches. Once damaged, it will never ever become normal. Okay? There's an overlay of wound healing. So what you're going to do now is, you're going to see the timeline and maybe a little bit about the process of how these are formed. Okay? Are you ready? Yes, I'm sure you are. You like to listen stories, right? We saw a story of wound healing. Now we are going to see the theory of wound healing. So now let's go to the exact steps of wound healing. Immediately after an injury, what's going to happen is, I'm going to have just a surgical incise cut. You're going to have a bleeding. I'm writing this because once they asked which is the first step, bleeding or clot formation. Few of them wrote clot formation. Obviously it is bleeding, right? It has to be bleeding. It's not that you don't know. It's an impulse. Like clot, hey, I saw clot, mark it. Just listen for 1 second in MCQ. You know the answer. After that you have a clot formation. Once a clot is formed, I'm going to call this clot as in scab. Scab almost forms immediately. 3 to 5 minutes, that's what I'm going to put as immediate. I'll have an immediate scab formation. In the scab, what happens is, then my next step comes. The scab, within 24 hours, the initial 12 to 24 hours, to be specific, I'm going to have neutrophils completely entering the scab. I'm going to have neutrophils in the scab. Lots of neutrophils. Lots and lots of neutrophils. Once I have neutrophils in the scab, the function of neutrophils is to remove any debris. This debris I'm including dirt as well as my bacteria. It's going to remove the debris. Once my debris is taken care of, I need one more guy to come inside who's going to be my macrophage. Right? Macrophage will come inside. At the same time, some amount of change also will start happening. So at around 24 hours, what I'll have is maybe around 24 to 48 hours. And throughout the time, I'm going to have few things happening. One in terms of making or bridging the gap. One in terms of covering the top. Around 24 to 48 hours, my epithelium at the cut end, my epithelium starts to form, slowly starts to form. Okay, it will start to form at the cut end. Fine. So that my scab slowly will be constricted and will fall off in some time. And around the same time, my macrophage also comes inside. Slowly comes inside. After 24 to 48 hours, my macrophage comes inside. And around third day, right? Around third day, what happens is, I'll have lots of macrophage. See, macrophage will not come at a third day. They'll come immediately after 24 to 48 hours. It will start coming. Why I'm saying third day is, when I'm going to look at a tissue in microscopy, I cannot say that, see, it is 12th hour, 13th hour, 14th hour, 15th hour. I can see a snapshot. So when I'm going to see macrophage, I'll see plenty of them in the third day. So I'm going with that. So around third day, what I'll have is, I'll have two things happening again simultaneously. My macrophage would have taken all the neutrophil, ate them, and also by the same time become an activated macrophage. Both happens kind of simultaneously, right? So what macrophage does is two things. Remove neutrophil and become an M2 activated macrophage. This M2 activated macrophage would have started my preliminary or an ill-formed granulation tissue around third day. Around third day, I'll have an early granulation tissue, very ill-formed granulation tissue. This is important. I'll tell why it is important to know this term. It's not a well-formed granulation, an ill-formed granulation tissue. For example, I had a gap here, like this, we had a gap here. Okay, how to put it? Yeah, like this, we had a gap here in my wound. Clot was in this place. So in this place, I'm having an ill-formed granulation tissue. Will scab fall off? It will. Next time when you fall down, watch, observe carefully. Around third day, scab will slowly start falling off because it means granulation tissue started coming, not excess. It has started coming. Only that for that reason I need to know this. So around day 5 is when I'll have a well-formed granulation tissue. So if your question it says that when do you see a granulation tissue, I'm not going to say day 3. I'll say day 5 because good guy, good person. When I'm looking microscopy, early granulation tissue I can mistake, but a well-formed granulation tissue I will not. Right? A well-formed granulation tissue. So what does this mean? So I need to know what is a granulation tissue, how it is being formed. The only person who would have helped me to form this, my beautiful macrophage, M2 activated macrophage. That M2 activated macrophage, see what I'm going to say is not going to happen exactly at day 5. It's going to start from day 2, day 3, day 4 and it completely forms at day 5. So we're going to see how a granulation tissue is being formed. I have two major things to happen here. One is neoangiogenesis. That's one of the major things. Other one is my fibroblasts. Okay. Other one is my fibroblasts. Both are required for me. Not only one, both. Neoangiogenesis will always be newly formed capillaries. They'll form only capillaries. They cannot form a big vessel. They can form only capillaries. For my capillaries to form, I need quite a few factors. The predominant one is my vascular endothelial growth factor, right? The predominant one here is my, what are the factors required for formation? All these factors are produced by whom? Perfect, your M2 activated macrophages. Gives me VEGF, vascular endothelial growth factor. We have fibroblast growth factor. I'm writing FGF for fibroblast growth factor. We have angiopoietins. Okay, all these guys are going to come and it's going to help me in my granulation tissue formation. Newly formed vessels. There are two things to learn here. How a newly formed vessel will be formed. There are multiple steps in them as well. I'm not going into each and every step. I'll just show you an image. That's how it is being formed. Okay, we'll go to an image and that's how granulation tissue is formed. If you look at this is an original vessel, the normal vessel. So when I have vasodilatation and VEGF, what's going to happen at this point is there will be an endothelial injury, right? That injury is what caused all the damage. At that point of injury, my pericytes are the cell which is covering my vessel. They get broken away. Once they get broken away, I'll have a tiny sprout. This tiny sprout also is brought about my VEGF only. The same VEGF brings this as well. Once a sprout comes, I know that I have two vessels here. Both will start sprouting. Then newly endothelium will be laid off. Then my basement membrane will be laid off. Then my pericytes will be laid off. One by one at a step. This is how it's being formed. We need not go into the depths of it. We know it's being formed like this. Only one I want to say here, maybe as an MCQ. What I want to convey here is, I have two vessels here. How will both the vessels know that I have to go in this direction only so that I can meet another guy? Why should I not go here? When I go here and one comes here, I cannot bind, right? Who tells me to go in the exact way is notch. This is important. There's something called as notch signaling. You must have heard about notch signaling in your embryology as well. Notch signaling directs the blood vessels to go in the correct direction, right? These are the person who are going to direct the blood vessel growth in the correct direction. Right? This is important for me. They're going to direct the blood vessel growth in the correct direction so that I know, okay, I have to go in this place only. When I go in this place, I'm going to meet my partner. We can join and we can create blood. Right? That's what is required for us. This is the only thing I want to add extra to existing knowledge. Right? Notch signaling helps to go in the correct direction. So once this happens, I'll have a perfectly newly formed blood vessel. At the same time, I need fibroblasts as well. For my fibroblasts to come, again I have few factors involved. Again, we're going to divide them into few factors. For my fibroblasts to happen, I need fibroblast growth factor. The major one is TGF beta. It's the most important guy. So this brings fibroblast. So what's the function of fibroblast? What do they secrete? They secrete, perfect, they secrete collagen. They want to secrete collagen. So I got my base already. I got my base on which my blood vessels can stay back, because blood vessels cannot hang like this. They need a base. Collagen is the base. Not only that, so this TGF beta does one more tiny naughty thing. It's going to help me to one more place. This TGF beta not only brings fibroblasts, they also convert few of the fibroblasts. They also differentiate few of the fibroblasts to myofibroblasts. They also going to convert. They also convert few fibroblasts to myofibroblast. This is important. This is extremely important. You are going to tell me why it's important. We started the steps of wound healing with the things that saying that I had a gap. So now what has happened is the top epithelium started around 24 days and it came and covered here. Let's assume like this. It came and covered like this. Okay? It came and covered like this. In between, what I have is all my collagen and everything is there. So what will I have if myofibroblast is not there? I have a place with collagen, blood vessel, epithelium. Right? That's all. Without myofibroblast, it will be like this. If myofibroblast comes in, myo, muscle, what property? Contraction. So this myofibroblast is going to make sure all of them is getting contracted with force and comes and seals. So I need both. These both guys will form the granulation tissue, and this guy of myofibroblast is going to contract and bridge the gap. Okay, contracts and bridges the gap. Understood? So both will happen almost simultaneously, and I'm going to see maximum granulation tissue around 5th day. I'm not yet done. So what granulation tissue will be there? How will I identify granulation tissue? How it will look? And what are the components in them? Components we know. Capillaries and collagen. We know that for sure. The collagen type is what we need to add. It will be in type 3 collagen. Early form collagen. A type 3 collagen will be there. Later it will change to another collagen, which will reach soon. Right? And have a type 3 tiny form collagen. That's how the granulation should be there. How do I pick them clinically? The clinical way to pick up the granulation tissues, they are newly formed capillaries. Am I right in saying that these newly formed capillaries will leak, will bleed? Yes, it will leak and it will bleed, right? So when it leaks and when it bleeds, a tissue here, it will have blood. It will bleed. It's a newly formed granulation tissue. It will be red and it bleeds. I'm sure you know this from your clinical scenario. I'll tell exactly where you must have read this. Surgery posting. Diabetic foot. You must have dressed a diabetic foot as an intern or sometimes during final year. When you dress a diabetic foot, your PG would have said, scrape the wound till it bleeds. When you reach the bleeding surface, you are reaching the granulation tissue. You know the basic science. I want you to link to the surgery during internship so that when you link and learn, each time you dress a surgery wound, you will remember granulation tissue, you will remember pathology, you will revise the subject. That's how you're going to revise. Apply everything what you read. So once I reach the bleeding tissue, I'm going to stop. I'm going to stop there because I know that this is going to heal. I'm not going to remove them, right? That's a healing tissue, right? This is a hallmark of healing. Okay, this is a granulation tissue, which is a hallmark of a healing process. Okay, that's about granulation tissue and how it is being formed. After granulation tissue, also the work is not stopped. Around first week is where good amount of mature collagen will be formed. Good amount of scar will be formed. Around first week, it will change to a scar. What happens mainly in a scar is my blood vessels will slowly start to go away from the granulation tissue, and the most important thing is I'll have type 3 will be getting converted to type 1 collagen. Why this is required? Simple reason. Type 1 collagen is the strongest. I don't want to have a weak collagen, I have weak scar. It will get converted to a type 1 collagen. Scar will start forming around first week. See, I'm going with a maximum scar deposition. I may not be exactly syncing with different books which you have been reading, but maximum scar deposition, as per good pathology textbooks, it says that maximum scar formation will be around 21 days. Actually, it's around 14 to 21 days. So I would say you remember it as 3 weeks. Around first week, my scar forms and maximum collagen deposition will be seen around 3 weeks. After 3 weeks, also I'm not done with. I'm going to have something called as remodeling. Modeling is very important, right? It's going to remodel. What I'm going to do during remodeling is I'm going to have few matrix metalloproteinases coming in. Remove the collagen, lay down new collagen. Remove the collagen, lay down new collagen. So that I'll have a perfect, at least near perfect scar. So the remodeling happens. Remodeling is nothing but to, with the help of few things called as an matrix metalloproteinases. These guys are also being secreted by macrophages only. I would want all these things to be applied when you come to neoplasia chapter. These macrophages will release matrix metalloproteinases and few other collagenases as well. MMPs, we have MMP 2 and 9. 2 this 2, 2 and 9. MMP 2 and 9 are gelatinases, degenerates gelatin, and we have MMP 3, 10 and 11. They are called as stromylins. This also helps to destroy a little bit of the collagen. Okay, stromylins. It degrades extracellular matrix, not only along with collagen, degrades a little bit of extracellular matrix as well, so that I'll make sure all the weak components are removed and I have new components, new and stronger components. And I also have interstitial collagenases. Okay, we'll also have interstitial collagenases. These are going to, they cleave fibrillar collagens. See, these are also MMPs. Okay, fibrillar collagen, these are my MMPs 1, 2 and 3. See, it's like an overlap. MMP is a group of enzymes which is based on the function of zinc. That's why zinc deficiency will have a defect in wound healing. MMPs are enzymes called as matrix metalloproteinases. Different groups, few of them do few functions, few of them do multiple functions. These are groups of MMPs, groups of enzymes which may be required for me, right? MMPs are family of enzymes which is going to help in degradation of collagen with the main help of zinc. Okay, zinc is it? Zinc and few more minerals as well, copper a little bit, zinc as well. So when I have deficiency of them, my MMPs cannot function perfectly. When they are not going to function perfectly, I may have a defect in wound healing. That's what I'm heading to, right? So once this happens, once the remodeling is perfect, at and around 3 months, approximately, I'll have a perfect scar or a strong scar. The strongest scar will be 70 to 80% of original strength. I'll have 70 to 80% of original strength. Never it will be completely strong. Never 100%. It's impossible to get 100%. Around 3 weeks, 3 months where I'll have 70 to 80% of the original strength of the wound happening. We are done with wound healing. We're done with the various steps involved in wound healing. Right? Just close your eyes. We'll just imagine. I want you to visualize like a 3D animation. I want you to visualize whatever I say so that you can be clear. Close your eyes. Close your eyes with me. Put your pens down. Close your eyes. Listen carefully and imagine. Take your skin. Take your hand. Take a blade and cut the hand. You had a bleed. Because of the bleeding, you had a clot formation which bridged the space initially. In that space, I'm going to have debris. Obviously, my neutrophil came inside. Bring your polymorphs. Mentally bring your polymorphs. Come there and let them remove it. They removed all the bacteria and waiting for something. The something is my macrophage. My macrophage was big and round and clear, came running and ate my neutrophils around second or third day. At the same time, look at the top. Something is moving on, which is my epithelium trying to get connected. Not only that, my macrophage after eating, it's saying like what I'm going to do. I have to bridge these guys. Okay, become activated, become N2 activated. Secrete VEGF, fibroblast growth factor, angiopoietin, and let the cut capillaries start progressing. How do they start progressing? At the site of damage, they sprout, They destroy the pericytes, they become leading edge. The leading edge slowly keeps on becoming bigger and bigger, and they have to connect. They have to go in the correct direction only. For that, I need knot signaling. Once I come in the correct direction, I have capillaries. I cannot be hanging just like that. I need the background. Fibroblast growth factor, transforming growth factor beta brings me fibroblast, brings me collagen. I had got a granulation tissue. But still I have the gap. What do? I have to contract. Okay. Change few fibroblasts to myofibroblasts. Bring in actin, contract the wound, seal the wound. This is a weak collagen. Convert them into type 1, become a scar strong collagen. Still I am weak. Bring in matrix metalloproteinase. Remove them, lay down, remove them, lay down. Make it much more stronger. So around the end of 3 months after this remodeling process, what I'll be having is I'll be having just a tissue with 70 to 80% of strength. That is what happens in wound healing. Clear? Just imagination. Imagination is the best thing you've got, and I want you to harness each and every bit of it. Now, we'll go to the biggest abnormal wound healing. Okay? We'll go to abnormal wound healing. We know about normal. Obviously, next we're going to say about abnormality, because we are into pathology. We are not into physiology, right? So, what all abnormality can have abnormal wound healing? We'll go to the simplest thing. I can have many different things, like for example, let's say a defect in the movement, anything. When I have an injury around the elbow, any joints, it'll move. When it keeps on moving like this, is it right in saying that the wound healing will be disturbed? Definitely. So mobility at the site of wound will disturb it. Which means around joints, wound will be a problem. Second, this is also your mom would have said. If you get around the knee, it said it's difficult to heal. Simple reason. Science. Next. When you have something called as when there's a less blood supply, my wound healing will be impaired. When do I have less blood supplies? Especially in diabetes. Same process happens in diabetes, but I have a vasculopathy. So obviously it's going to affect my blood supply. During vasculopathy, wound healing is going to be defective. So indirectly diabetes. Okay, steroids. Steroids will reduce TGF beta. When they reduce TGF beta, my wound healing or scar will be defective. I'll have a defect in scar formation. Vitamins, vitamin C, less collagen production, because you guys know that vitamin C is very important for collagen formation. Micro thing like minerals, zinc. When zinc is abnormal, I'm going to have less matrix metalloproteinase, less wound healing, or ineffective scar formation. I'll have scar, but not so strong. I'll have a problem there as well. You guys know these. All of this you don't want me to say. You definitely would have imagined all these guys. I'm going to say three things. One is something called a proud flesh or an exuberant granulation tissue, and obviously a famous hypertrophic scar and keloid formation. Those two things, yes, I am going to explain to you. The first thing I'm going to call is an exuberant granulation tissue. Granulation tissue is good for me, but we always know that too much of anything is good for nothing. Exuberant granulation tissue is also called as a proud flesh. See, the simple thing, my granulation tissue is being formed too much, more than what I require. Let's assume this is a normal wound. That gap is the wound, fine? If it is normal, what will happen is, I would have had granulation tissue like this. Okay, I'll put a pink color granulation tissue. It will bridge the place and slowly it will heal. Normal, completely no problem. When I'm going to have proud flesh, we're going to see what will happen. Proud flesh is nothing but same wound, but I'm having so much of granulation tissue. So much. Too much in excess. So what is the problem here? Problem is, look at the epithelium, it's stuck. It cannot bring like this. Right? My head is like the exuberant granulation tissue. My skin is here. It's just putting the neck out and not letting my skin to approximate. It's going to be a problem. So what do I do to prevent this? Simple. Behead. Right? Remove the excess granulation tissue, remove the proud flesh, it will go to a normal wound healing. The problem here is, it will affect re-epithelialization. Okay, it'll affect re-epithelialization, right? So obviously treatment is to remove the excess, chop off the excess, so that my skin can easily get approximated, so I can have a good wound healing. That's my first thing. Second thing, I'm sure most of you will know, hypertrophic scar versus keloid formation, right? This is being asked in your, must have asked in your surgery postings, YY in pathology, short notes in pathology, as well as surgery, right? We'll see the difference. Hypertrophic scar or keloid formation. Main differences. Keloid has a racial predisposition. Asians and Africans have more chance of keloid formation compared to Americans, compared to whites. Okay. Hypertrophy scar, less. There's no racial predisposition. No racial difference. All of them have equal chance of having a keloid formation or a hypertrophic scar formation. So, hypertrophic scar are asymptomatic. They don't have symptoms. Just a scar which is bigger, that's all. Keloid can be asymptomatic, or it can have itching or pain. It can have both itching or pain. Next. Hypertrophic scar resolves on its own. Resolves in 3 to 4 months for sure. They don't have a huge problem. They'll resolve in 3 to 4 months for sure. Keloid will never resolve. They never resolve. They'll be there for sure throughout life. Okay. Some of you would have had keloid formation for sure. I also have a thing. I have a keloid here. I'm not sure it's visible. There's a keloid. It's been there from the past 10-15 years. It's not changed, but it's asymptomatic. Just maybe ugly, that's all. Right? So these are the main differences clinically. So how do I differentiate? By examining the patient. I'm not going to differentiate by microscopy. I'm repeating, I'm not going to differentiate by microscopy. It's totally a clinical difference. On examination is the final say. The best thing to say is, an hypertrophic scar will never cross wound margin. Never crosses wound margin. I'll tell what do I mean by this. This almost always crosses wound margin. I'll tell what do I mean by this. Let's assume there was a wound of this extent. The tiny gap is the wound again. If I'm going to have a hypertrophic scar, maybe it will become like this. It is big. No doubt it is big. It will be bigger than from the skin. But it will not cross the wound margin. This is my wound margin. It will not cross it. It will be within it. Maybe it will become top. It will become grow on the top, but not sidewise. But a keloid will cross wound margin. If this is my wound margin here, see this is a tiny wound margin, it will cross them. It will cross them. The best sites for keloid is earlobe and sternum. Okay. Sternum is more common as well. Fine. I'll show you an image so that you can be sure that it will cross wound margin. I'll just show you an image of keloid. This is an image most of you would have seen for keloid as well. Fine. Look at this. This is a keloid in the earlobe, in the lobule, after an ear prick. You must have had a prick. That tiny little prick, tiny little, maybe 0.5 centimeter, that has got a huge mass. Has it crossed 0.5 centimeter? Yes, it has crossed the wound margin, for sure. So if I go and look at the microscopy of keloid, this is what I'll see. I'll have bundles of collagen. What I'm going to see here is, you're going to have bundles of parallelly arranged collagen. See, this may not be required. This is not how I diagnose keloid. Keloid is diagnosed clinically. But if I take a microscopy, I'll have bundles of parallelly arranged collagen. Now a question comes. You're going to say that I'm having something pink in color. Collagen is pink in color. What else is pink in color in my microscopy? Protein is pink, plasma is pink, every damn thing is pink. I will not be able to understand this is collagen or amyloid or protein or anything. What do I do? What do you do? Perfect. You ask for a special stain. The special stain for collagen is Mason's trichrome. Do write this down. We'll read them whenever we require. The special stain for collagen is called as Mason's trichrome. It's called trichrome because it has 3 colors. I'll write that in the whiteboard. Fine? We have 3 colors. The stain for collagen is trichrome. I'll come to this table again. Maybe put a tiny box down and write this. We have Mason's trichrome. There's 3 colors: blue, red, and black. The most important is blue because collagen will be blue in color, right? Because collagen will be blue in color, that's the most important thing. Red color, fibers, muscle will be red in color commonly. Black color, nucleus. Okay, nucleus will be black in color in Mason's trichrome. Mason's trichrome can also be abbreviated as MT. Abbreviation is known, you have to know it. So that's one more new stain in our armamentarium. We are preparing ourselves for the war of hematology and systemic pathology. After finishing general pathology, we have everything set for us. We are just going to fire at Robin's pathology book with our knowledge so that the pathology book goes into pieces. I want you to make sure, spend time and read general pathology. Right? Let's go back. So that's the difference between keloid and hypertrophic scar. Treatment just to complete. No treatment required because we know that it resolves on its own. Then why do I want to treat? Just wait for some time, reassure the patient, it will come back to normal. Steroid. Treatment is keloid, the treatment is intralesional steroid. Especially I want a long-acting steroid. Triamcinolone. Again, you must have read this in your pharmacology. I'm going to give a long-acting steroid inside the scar. When I give it inside the scar, we know that steroid will reduce TGF-beta. When it reduces TGF-beta, less collagen production, it will not progress. Whatever was there also slowly will become weaker and will be destroyed. That's the logic behind giving steroids. Okay? I just want you to link this to a clinical scenario. If you have been to a surgery posting, if you have taken a case history for any surgery, like let's say in thyroid or breast cancer, you have to do a surgery. For sure, some thyroid or cancer, you have to do a surgery. There will be a point in history called as previous surgeries. I'm sure you must have done that. You must ask, did you have any previous surgery? They will say, yes, appendix was there, then you're right. Previous year, appendicitis was there, no problem, that's all. The history is asked for a reason. What makes you the best doctor from an average doctor to know the reason? Why do I want to know a previous surgery? How does an appendicitis affect a breast cancer? No. How does appendicitis affect the thyroid cancer? Nothing. But what is common between them is wound healing. The purpose of asking the surgery history is, past history of surgery is, I want my young undergraduates to go and examine the scar, not just ask. Look at the scar. Is there a keloid? If there's a keloid, is there a chance this scar also can have keloid? Yes. Can this keloid be disfiguring? Yes. Tell that to the patient before. That makes you the best. I want you to tell that to the patient. See, you have a tendency of keloid formation. It's not because of me, it's because of you, your genetics. I want you to make sure this time also again you may have an abnormality. I'm not saying you will, you may have. I'm just priming you so that you don't get a bad name. See, that tiny nuances makes you the best. And I want you to be the best version of yourself. Next time, when you ask a past history of surgery, in your surgery clinical posting, go and examine the scar. Tell to the sir who asked you the viva or your professor, sir, I examined the scar, there's no keloid formation, the scar was perfectly healthy. So I presume that this scar also will be healthy. He will think, wow, this guy is good. I want every senior of yours to think you are good and you believe you are good. Right? That's about wound healing. That's all for this module. Get back to your coffee and go back to the next chapter. Meet you again with one another episode and we'll see amazing. We'll read amazing. Okay? Till then, bye-bye from Dr. Ranjit. Bye-bye.